All right, it's right after 1800. I'm gonna go ahead and get started. At least the first part will have to be recorded. Tonight, we're gonna move kind of quick tonight because we got a little bit of catching up to do, and it will be dependent on you doing some self-study at home between now and our next class, or before you do your modular test. But tonight's chapter 8, Pathophysiology, and it's chose to do the comprehensive lecture as it covers most of the points. The pathophysiology. This is simply where it This is simply the knowledge and it's the study, pathophysiology of major human system. It integrates comprehensive knowledge that we've taken on before, build on to what you've learned in the past, and continue to build it from here forward. So this patho A&P applies to every chapter or every system that you'll cover. So tonight, pathophysiology is the study of physiology, which is the function of organs and altered functioning in the presence of some type of disease. For example, when the body can no longer maintain homeostasis, disease may start to result. And we remember homeostasis is the point of where the body state of normality, if you will, what the body has to do when they to maintain your normal everyday functions in a healthy individual. So pathophysiology is the study of altered functioning in the presence of disease. When the body can no longer maintain that homeostasis, then you will start getting some disease factors. To understand this process, we've got to understand the way disease alters the structure and function in the basic unit of the cell. Cells, for the most part, they have to adapt. When cells adapt, that it expands to the tissues, and tissues depend on that changes the systems, which changes the complete organism. So these are some terms that you'll need to study and know these terms. Like I said, you'll hear this throughout your medical career, at whatever level you go to or stop at, but you'll always hear these terms. So there again, like I said, we're going to move fast tonight. Got a lot to cover in order to be able to get caught back up for next week. So you'll be dependent to do some self-study at home in your text, online materials for that matter. So let's look at some of these terms tonight. Cells undergo a process of adaptation when they're exposed to adverse conditions, any type of stress, injury, disease process, or things that may injure them or alter them. So atrophy, you've heard of things like when they have muscular atrophy, or their organs have atrophied to the point that they're no longer useful. Atrophy is a decrease in the cell size due to a loss of subcellular components. In other words, the muscles will deteriorate if you don't use them. You constantly have to use your muscles to have them to build up, to get adequate nourishment in them. So when muscles aren't used or cells aren't used, they decrease in size, they atrophy. Hypertrophy, anytime you have hyper in a word, it means that is more than normal or in excess. So when you got hypertrophy, it's an increase in the size of the cells due to synthesis or more subcellular components. For example, they may get enlarged. They could get fatty involvement. Or, for example, and we'll talk about later, like if a heart is overstressed due to hypertension or overworking, it's just like a muscle in your arm. If you work it out, it gets big. Now, a heart is it's supposed to be strong, but when the heart has to overwork due to compensate for hypertension or pulmonary hypertension, for that matter, that heart muscle gets big. When the heart muscle gets big, the ventricle decreases in size and less fluid can get through. So that's not a good thing to happen. So hypertrophy is an increase in the size of the cells. Hyperplasia is an increase in the actual number of cells in the organ. Plasia is normal growth. I mean, the normal growth, the life cycle of a cell. Now, hyper means above. So if you got something growing too fast, you got to think of stuff like cancer or obesity in an effect when you got an increase in actual number of cells in an organ or tissue, like fatty liver. You have fat cells replacing normal liver cells, so that is a form of hyperplasia. But for the most part, it's talking about like cancer. Now, when you see the term dys, D-Y-S, that means difficulty or abnormal. So dysplasia is an alteration in the size of the cell, shape, or organization of those cells. And metaplasia refers to reversible cellular adaptation, like when one adult cell is replaced by another, kind of like when it dies off, then another one takes its place, like normal growth factors. When homeostasis is interrupted, whether it's from disease or overworking or some type of injury, it, for example, the body is mostly water. So it's like when they cremate somebody, all the ashes that they have left over might fill a quart jar. So the body is mostly water, and which means changes in fluids and electrolytes that disrupt homeostasis can cause or exacerbate various medical conditions or disease processes. For example, excessive output or input of fluids can upset homeostasis. If you get too much fluid on board, the cells, you can do an electrolyte shift. You can displace types of sodium. Your electrical impulses won't fire as good. Muscles won't contract as good. And excessive output, like in dehydration, you'll lose like sodium, potassium could come out, and there again you'll get just the opposite effect. So the one thing you'll remember when we talk about sodium in just a minute is wherever the water goes, that's where wherever the sodium goes, that's where the water wants to go. But the degree of fluid imbalance, it depends on the patient's size, their age, any underlying medical conditions. And as we get into the AEMT portion, fluid therapy, that's a fundamental step in resuscitation. Your body has to have an adequate amount of water, the proper amount of water in order to be able to function, because everything, that is the life juice of life forms. Now, too much fluid, or maybe it's not really too much, it's just not in the right place. So, example, you hear somebody that says, well, I can't have sodium, or because the sodium stays in my body and the water's going to follow the sodium. Sometimes the blood vessels get so permeable, or they lack the ability to control fluid, that's when the fluid will leak out of the capillaries, and you'll see fluid like in the lower extremities, like under the arm, sometimes in the back, they'll have these areas. But edema is swelling by excessive fluid trapped in the body tissues. Capillary hydrostatic pressure, like I said, more fluid that is being retained in the body than the capillaries can hold, they start to leak out. Allergic reactions or inflammation, they can cause venous obstruction. Pregnancy can cause this. Heat stress. Heat. Why does heat? You think you would sweat it out? What's happening there is a lot of times heat will cause you to lose water, but not necessarily a whole lot of sodium. But if you lose water and the sodium stays in place, it's going to draw whatever water that's in the cells out into the vascular system. That's one reason you'll see swelling with that sometimes. Allergic reactions, things when the cells start to inflame, blood vessels and capillaries lose their ability to hold the fluid in, and you'll get that capillary permeability, and that'll start swelling. That's why you have swelling in like anaphylactic shock. Sometimes the osmotic pressure in capillaries will decrease, and it has to have some type of pressure on both sides in order to be able to keep it in place. But when those electrolytes or fluids are excess or lost, then again, it will cause shifts and fluid will get to where it's not supposed to be. So how do we know if someone has a lot of fluid on board? Well, obviously, sometimes when you do these exams and patient assessment, we'll start next week. Excessive fluid, you think about congestive heart failure or pulmonary edema, some things some people will get will be like in pregnancy complications where they'll start to swell and retain fluid. But when we start to, the first thing we want to check to see is we'll listen to lung sounds, osculate breath sounds. If they're backing up fluid into their lungs, you should be able to hear rales and rhonchi. Lung sounds will be discussed a little bit later. But auscultation of breath sounds, you'll look at the feet, also the sacral area. Do they have any jugular vein distension? And do we go after just treating the fluid or something like that? Not really. You need to find out what's causing the problem. If you just say, well, they got fluid, I'm going to give them a bunch of diuretics, you're just putting a Band-Aid on it. It's not really going to work that way. So we need to find out what's actually causing this problem. Isotonic is a word a term that you'll need to remember, because when you give IV fluids, there's going to be hypertonic infusions, isotonic infusions, and hypotonic infusions. Now, tonic means the amount of solutes that's actually in your blood, that's in the body. IV isotonic fluids are like normal saline. That is the same amount of sodium in your blood, in your cells, that's in the bag of normal saline. So isotonic fluid, it is when you put that into somebody's system, it's mainly to control volume. It doesn't pull anything out of the cells, and it really doesn't put a lot of things into the cells initially. Now, after a while, if you put it in fast, it's going to come out fast. But if you put it in slow, like sometimes they might say, let's give 250 cc's an hour, that will have time to get into the system and nourish the cells and increase sodium content. But for the most part, it doesn't shift a lot. It's mainly for volume replacing. Now, later on, you'll learn about hypertonic solutions, and that simply has more. It has more saline in the IV fluid than it does in the cells. What happens with that is, say, like if you want to increase, it'll increase blood pressure shortly. But let's say if you have a lot of edema in the brain, those blood cells or those cells in the brain might have a lot of swelling due to an injury or a head injury. They'll give this hypertonic solution, like 3% saline, and what it does is it actually pulls fluid out of the cells to try to reduce that pressure. That's where things like that will work. Now, somebody that's severely malnourished, I've seen them with alcoholics and stuff like that that have the DTs, they may give a hypotonic solution, because what's going to happen there is there's more solutes in the blood than there is in the IV bag. In that IV bag, they may have some potassium, they call it a banana bag, or some vitamins, things of that nature. And since it has a lesser content of sodium in the fluid, your cells are going to pull that in for nourishment. But when you have an excess, a deficit of isotonic fluid, the extracellular fluid will start losing sodium and water, because it will start pulling it out of the cells. Isotonic overload, or when you got too much of it in proportion to, like, if they get a fluid overload too much, it's hard on the lungs and the kidneys. If the kidneys can't take it out that fast, and it's going to back up into the lungs and the heart and cause some pulmonary edema and difficulty breathing. As y'all can see, I'm having an issue again here with my PowerPoint. Now, sodium is the chief extracellular ion charged atom. Wherever sodium tends to take water with it. So you've heard of people like, maybe I can't have salt. What that does, they get all that salt in the body, they retain fluid, and they'll start getting edema. Maybe high blood pressure people are like that. If you think about it, I can't have a lot of sodium. Well, more fluid you have in your vessels, the higher your blood pressure is going to get. When you're so if you got a lot of salt in your body, it's going to keep that. It's going to pull more fluid out of the cells into your bloodstream, and your pressure is going to go high. That's bad on your kidneys. It's bad on heart function, because it's going to cause fluid to possibly trap in your lungs. So sodium regulates fluid balance, total fluid volume, and blood pressure. Sometimes your kidneys may need to release sodium, and sometimes they hang on to it. But these numbers here, you're going to have to know some lab numbers. In the field, no, you're not going to have to quote, oh, his sodium level is this. This just gives you something to kind of base your knowledge on. I believe that instead of teaching just what, kind of the how needs to be something in there as well. This just simply helps you understand a little better. But hyper, there's that word again. Natremia, natrium is NATR is sodium. NAT, and how you see that? So hypernatremia is an excess sodium level. Normal sodium is between 135 and 143. But anytime you get a serum level of over 143, it's hypernatremia, and sometimes when it gets below that, you can get a low sodium level. And why is that important? You can have heart arrhythmias. You can have people can go into seizures. Certain types of medication, they may have to check your blood levels every 2 to 3 months to check your sodium level. You may have heard of that before, but that's why, because it some medications may interfere with sodium balance. Sodium is also important for muscle contraction, nerve impulses. Potassium plays a part of this role as well, but sodium and potassium they work together, but opposite like. They can't really occupy the same space, but causing them to switch places sometimes is the reason some things work, like in muscle contraction. So some things that will cause hypernatremia, of course, is if you have a lot of water loss but no sodium loss, or if you ingest a lot of sodium through the diet, or your kidneys might not be functioning right. Some causes of hyponatremia is excessive sweating. Excessive sweating will cause both of these. One, if you lose sodium along with the sweat or the water, and the other one is if just the water goes away without the sodium. Also, gastrointestinal losses through vomiting, nausea and vomiting, and inappropriate use of IV fluids. I heard somebody the other day, it was shamefully to admit it was a relative, who I don't claim very much, but she said that if she could just get a hold of IV fluids, she'd go give them to her grandmother. And it's like, you work in administration. Well, what could it hurt? Well, I'll tell you, you give too much sodium to somebody that don't need it, you can kill them. You can, you kind of know what you're treating. It's not just that simple going and sticking that in somebody. So inappropriate use of IV fluids can cause problems. You give a hypertonic solution to somebody that's already dehydrated, and you can put them into renal failure. You give a lot of fluid to someone whose kidneys function is not working right, and there again, you can put them into renal failure, and they can actually drown in those fluids. That's why a lot of times before they do a test of needing like IV dye or anything like that, they'll do a creatinine test. They check kidney function to see how your kidneys are functioning right. Now, potassium, this is the biggest intracellular ion. And potassium is it doesn't take a lot. When we see this word here, the MEQ with a back / L, that means milliequivalents. That's kind of the way some things are measured in milligrams or grams, cc's, but milliequivalents is something you'll hear a lot of the electrolytes measured in. Potassium, bicarb, things like that will be in milliequivalents. So what happens here, it's responsible for heart function, muscle function, a lot to do with muscle transmission within the brain, and it's got a very short range as well, 3.5 to 5.0. We're not going to measure that in the field. This is simply for informational purposes. If you choose to go on to paramedic, critical care, flight medic, nursing, or anything like that, then you will touch on these a little bit more in depth. But hypokalemia, there again, that word hypokalemia, or K means potassium. That's the symbol for potassium. Anytime you see the word emia, that's blood. So you got hypokalemia, that's decreased blood or potassium in the blood. Some causes of that would be just simply not eating enough of the right foods. A decrease, maybe the ions will shift into the cells, for example. If the cells become dehydrated, a lot of times it will pull the potassium out of the blood for use. Renal potassium loss, sometimes the kidneys will excrete more potassium than what they're supposed to through some type of medical problem or medication. And hyperkalemia is too much. Of course, you can eat too much of it. The body may not excrete what it's supposed to. The kidneys may retain it and it remain in the bloodstream. There again, what happened with it out of the cell, it can be shifted again, and it can release it out into the blood. And of course, excessive dietary potassium intake. Now, I've worked places to where like offshore sports and things like that, where they'll give people start sweating and having cramps, and they'll start giving them potassium, and sometimes large amounts of it, which uh, they would give them that a lot with no sodium, but they need each other to work right. And they would have them eat a pickle or drink some Gatorade, which only doesn't have very much in it at all. I mean, the best thing to take right after somebody has sweat a whole lot excruciatingly is, of course, water. For about every water, then you might take some, for about every 3 to 4 bottles of water, then maybe you can have a Gatorade or Powerade or something of that sort. So one of the biggest things I found that would get these guys, if they would get to the point where they was having severe muscle cramps, is some of the rig managers would have V8 on hand. If you look at the amount of sodium and potassium in a V8, they would drink they drink a couple of pints of water and drink a V8 in there, and that would relieve the cramps and everything a lot quicker than the some of the Powerades and stuff was. So that's just, and it's the reason I tell you that, I'm not advertising V8, I'm just saying because of the potassium and sodium loss. Calcium has a lot to do with heart function, mainly found in the bones and the teeth. It's kind of a hard compound. It's in your blood floating around, but like it helps to form collagen and matrix of the bone to make it strong. And the way it gets in there is through the gastrointestinal tract. You don't automatically make calcium. It's got to be ingested. You got to be able to have the adequate dietary intake of it. And of course, not only that, it has to be able to be absorbed. Normal calcium, as you can see there, is 8.2 to 10.2 milligrams per deciliter. Like I said, it's just FYI. And hypocalcemia is a condition when there's not enough calcium in the blood, and it can happen from like not enough intake, or maybe they'll take it, but it's just not absorbing. Increased calcium loss, sometimes bone disease, not getting nourished a lot, and your body will pull that from the blood, from the calcium, from the bones, and endocrine disorders. Sometimes hypogonadism for males and things like that will cause your body to pull excess calcium from the bones. Another one is sepsis. Sepsis will cause your body to lose a large amount of calcium. If you've ever heard of milk fever, sometimes seen in dogs or animals that are nursing, and you do have some calcium storage in the muscles, and if they're deficient in calcium, like the mother, I've seen the dogs, especially the babies will be nursing, and then the dog they have a constant twitching. It's just like they go into a constant seizure and they'll get real hot. They call that milk fever. And what's happening is to make milk, there's not enough calcium in the blood to sustain it, and it starts pulling it from the muscles. And without the proper amount of calcium, potassium, and sodium in the muscles, they can't contract right, and they'll start having these severe muscle contractions. It's not really a neurological seizure, but it's severe muscle contractions, and it generates a lot of heat. They can get febrile, and it can kill them. And the way they treat that at the vet is they'll give calcium gluconate IV to reverse that. But anyway, that's just a little information about how that calcium can actually work on muscle issues. I've seen people in dialysis have issues, and you can't really come in and say, hey, that's what this is. You got to treat everything according to your protocol and local guidelines. But turned out later they was low on calcium, and it caused activity that actually looked like a seizure. Hypercalcemia is increased serum blood calcium. It can happen because people actually take too much calcium. Some of these supplements that people get, for example, you might have calcium in like CalMag, or it may have enough already in a general vitamin someone takes. Now, right now you see a lot of read labels. So this doesn't have to do with calcium, but in comparison it will. Like right now, everybody's trying to get this vitamin D because they say it helps fight COVID. Well, the other day I was looking for some vitamin D, couldn't find any, so I started looking at some other things. And I already take fish oils, and I looked at fish oils, and it also contained the proper amount of vitamin D. Then I looked at the regular vitamin I was taking, it already had vitamin D in it. I'm thinking, my gosh, here I am. My body was wasting that other because this had the tendency to get rid of what it don't use. So read the labels, you may be already getting stuff. And then I seen this supplement called zinc, calcium, and potassium all together. Well, how many people do you think, which before I read the label, almost reached and grabbed that? when if you look at your multivitamins and your other ones, it may already have those products in it. So read labels and be careful how you might say, well, how did Grandpa get too much calcium? He has a glass of milk every morning, then some Ensure, and he eats a cup of yogurt, and he takes his calcium. I mean, so think about how that could all be happening. But endocrine disorders can cause the hypercalcemia, not excreting it like it should, and certain types of cancer can as well relate to that as far as not letting the body function properly. Now, this is just simply a picture to kind of show how some of the electrolyte imbalances might happen, like low blood calcium, hypocalcemia. The thyroid, how does that work? It increase some levels of vitamin D production from the kidney. That's if it's low, to try to make up for it. Then you can see where the under high blood calcium, how it may work. The small intestine, how it absorbs or may not absorb is right. There's some issues that could be going on with the intestine that cause you not to absorb these electrolytes. And then you can feel free to view this slide later on, but like the way the kidneys work, whether they hold on to it or whether they let it go, it has to work properly to form that balance. Now, if they have kidney dysfunction, which happens a lot of times with dialysis and patients with high blood pressure that are on a lot of medications, they may have a real fine balance. So a lot of them think that these over-the-counter things don't have anything to do with it, but they very well can. So just be sure to read your labels and follow instructions. Phosphate, it's for the most part, people don't have a lot of issues with this. It's intracellular. It used to maintain a lot of body functions. It can what can cause those low hypophosphatemia, simply not getting enough in, or taking too much diuretics, high blood pressure issues, taking diuretics, Lasix, things like that can cause people to lose a lot of that. Electrolyte abnormalities, loss of nutrients followed by inadequate replenishment. A lot of people go on these diets and they'll simply get rid of like, I'm not eating any carbs. I don't care what else it is, but I'm not eating any carbs. They'll do away with vegetables and fruits and things like that. However, that's where a lot of nutrients are. They may lose a lot of weight. I went on a diet back in the mid 90s in order to be able to fly. I lost 30 pounds in about 33 days, but I got real sick with some kidney issues. And my doctor says, man, keep it up and you'll be the skinniest person in ICU. So you can't just forego everything but one group, because you got to have things to replace what your body uses. So too much phosphate in the body, again, can be due to over ingestion of it, or simply not letting the urine or the kidneys excrete it out, because the kidneys do play a big role in this. And if you do a lot of dialysis transports, I bet you somewhere on one of those walls it has a warning about food, and it'll have something about phosphate. And there's a warning about how to control their diets with that. Magnesium, most of it is stored in your bones, the other half in your body cells, and in some other, of course, is in your fluid as well. The magnesium has a lot to do with heart rhythm, has a lot to do with muscle contractions. It can has a lot to do with let's see what I'm trying to word I was thinking about. It even can work with your blood pressure. So some decreases in magnesium can cause just simply not enough, the proper intake of it, the way it's absorbed, the way it's not eating right. Now, it is in a lot of vegetables. However, there's not you actually have to eat a lot of vegetables to maintain that. But things like diabetes, respiratory alkalosis, and pregnancy, they can actually cause your body to lose magnesium. That's one reason people that are pregnant females, like, they get eclampsia. And one of the things that causes eclampsia is the loss of magnesium. And the way they will treat those seizures or even preeclampsia, the way they treat that is magnesium sulfate infusions. So that can it makes your body form a fine balance as far as keeping your pressure and your muscles and everything contracting right. Too much of it can also cause an absence of reflexes and neurological depression. If someone has what they call mag toxicity, one of the first things they'll lose is their ability, like deep tendon reflexes. You know, if you stop and think about some of these energy drinks and some of these foods that a lot of, I don't want to use the wrong term and upset anybody, but a lot of people that are constantly going to the gym and stuff to work out, and they take all of this excess creatine or excess energy drinks. It may have, say, oh, we got a lot of potassium in there, we got a lot of sodium in there, but too much of that stuff, your body's not used to it, and it's not going to be able to function right with it. So just please think about that if you start putting some of that stuff in your body, because your body might not be able to handle it all. Now, some of it may even be damaging to your kidneys over the long term. Let's talk about pH. We're going to talk about acid-base balance a little bit. pH is the concentration of hydrogen ions in your blood. Your body can only tolerate very small fluctuations in pH. The average pH level for a human being is 7.35 to 7.45, slightly on the alkalotic side. And you'll hear about this a lot throughout, but it's something that'll be in your medical career as long as you stay into it. It'll get more intense as you go on with it as well. So you've actually, if you've been an EMT for a while, actually worked in the field for a while, you've worked on pH a lot, and you've seen the effects of it, whether you knew what you were looking at or not. But the lower the number, the higher the acid. 6 has more acid than 7. So, and it goes in the opposite way. It's a base. The stronger the base is. But acidosis is a condition of a low pH, anything below the norm, which for us is 7.35. It's acidosis, and it's because of the increase in hydrogen ions, and the number will get lower. Anything below 6.8 can be fatal. And this has to do a lot with, for the most part, potassium balance.
What was that number again, Lynn? I'm sorry.
6.9 to about 8.0 is what they say that is compatible with life. You know, the extremes. The norm that we want to stay between is 7.35 to 7.45. I tried to work on my PowerPoint thing today as to why it keeps going off, but I'm not sure. This is just a rough kind of a scale the way this is supposed to work. Now up at the top you see 7.4 range is kind of what we want to stay around, 7.35, 7.45. Your body has to have some of the hydrogen, we're called carbonic acid, to keep in balance. But the bicarb is the buffer to raise it to a base. Now, so it's kind of a balance of what has to happen. So let's say, for example, if you got it's like this on the one on the scale says you got probably 7.1 on the pH, and we need to get more towards 7.4. Now your body may start releasing bicarb from the duodenum or from the buffer system of the body to try to bring that back to normal. Now that didn't happen right away. It takes a little bit longer for that. One of the biggest things for acidosis, respiratory acidosis, is hypoventilation or not adequate breathing. Not enough breathing is going on. So what happens? Is it really the lack of oxygen in there that's hurting you? Not as much as it is the excess of carbonic acid that's building up. Excuse me, or CO2 that's building up. That's the big thing it's getting you. And the cause of that, there again, is hypoventilation. It could be from airway obstruction, cardiac arrest, overdose of a CNS depressant that's causing you not to breathe that good, submersion in the water, respiratory arrest, pulmonary edema. The lungs are full of fluid. They can't make it gas exchange. They can't get enough air in. A closed head injury causing someone not to be able to breathe properly. And of course, chest trauma, not being able to take a deep enough breath. They can have a pneumothorax, hemothorax. Some signs and symptoms of respiratory acidosis. Like I said, you've probably seen this before. Systemic cerebral vasodilation. Now, what happens with vasodilation? A lot of CO2, carbon dioxide, or carbonic acid causes the vessels to dilate. If that happens, what else happens? Your blood pressure is going to go down. One of the factors to this is it's a kind of a safety mechanism where in the brain, remember the reticular activating system kind of goes haywire. It's not acting right. So when it gets too much acid in there, it dilates blood vessels, which cause an excess blood flow to the brain. It can cause intracranial pressure to build up. And that sets a myriad into effect. You'll learn more in trauma. But that's what happens with that. Those blood vessels dilate and the blood pressure gets low. Hence, somebody starts going into cardiac arrest by not breathing or not breathing good enough, or with too much CO2, they'll go into cardiac arrest because the blood pressure gets so low. Some other symptoms before that happens you might see is headache, lightheadedness, flushed skin because of the vasodilation, CNS depression, slowing respirations, nausea, vomiting. All this can be a part of the acidosis that's occurring. Now, respiratory alkalosis is associated with hyperventilation. Think about someone that is hyperventilating. They're blowing off more CO2 than it takes to keep the body regulated. Like I said, you got to have some. So that's respiratory. Now, metabolic alkalosis can occur because of something as far as like ingesting too much, like a bunch of sodium bicarb, or ingesting a big amount of the base. That can cause the alkalosis metabolically to shift. Respiratory has to do with the ventilation part. Metabolic has to do with something from within, usually, some type of ingestion. So respiratory wise, drug overdose, a stimulant or something like that makes them breathe very fast to blow that off. Fever can cause excess ventilations that can cause someone to get alkalotic. Also, bagging somebody too fast. If somebody in cardiac arrest or needs help, they really don't need to be breathing their actual amount of times as to what they'd be breathing without help. 12 to 16 times for an adult is usually enough. If you start blowing off too much, then you're going to start contributing to that shift. You're also going to cause too much air to be built up in the chest cavity, which reduces blood pressure, force of contractions, and things of that nature. Now, this doesn't really go into it a lot here at this level, but one way we used to remember it on the helicopters, well, how do you know the difference, respiratory or metabolic? Of course, you have to see some lab work and things like that, but if you were working on a monitor, if you're trying to get rid of CO2, you got too much. If they're hyperventilating, they're trying to blow off the excess CO2. So the way we would work that, and they'd breathe harder and deeper to try to blow it off. And blowing it off is what that causes, blows it off too much. So if we had someone with a low pH, but their CO2 was high, we would breathe harder for them and faster. Just the opposite. If the pH was high, showed that there was an alkalosis, and their CO2 was low, we would actually slow respirations in order to allow it to build up. The metabolic is not easily treated that much outside the hospital, but that's when they might have to start giving sodium bicarb and things of that matter. Now, you may have been on cardiac arrest before to where they'd been down a while, and they would give sodium bicarb in a cardiac arrest because they're trying to shift it out of acidosis, because if they've been in respiratory acidosis for a while, metabolic acidosis will follow. So some signs and symptoms of that, of course, the decreased LOC, carpal pedal spasm. If they're breathing real fast, hyperventilating, you'll see the fingers, the wrists start to contract up, sometimes the feet. Sometimes they'll get numbness around the lips and the face, chest tightness, confusion, vertigo. That's just some things that they could develop in there that might be as far as respiratory alkalosis. Now, metabolic acidosis, some of those causes can be, for example, like lactic acidosis, ketoacidosis, aspirin overdose, because aspirin is an acid, excessive alcohol ingestion, gastrointestinal losses, carbon monoxide poisoning. Some signs that you will see with that is some vasodilation, because there again, it's due to the increase of acids in the blood. Warm flushed skin, tachycardia, nausea, vomiting, cardiac dysrhythmias. Metabolic alkalosis, and if you lose too much acid, you can get, that comes like from excessive water intake. What you're doing, you're becoming water intoxicated. You get so much water in there, it distorts the electrolytes, and the things are not going to function just good. Someone vomiting too much, nasogastric suctioning, which is doing pretty much the same thing as watering. Excessive vomiting. Too many Tums, Rolaids. Some people take sodium baking soda, mix it up in a glass and drink it for heartburn, but too much of that can cause metabolic acidosis or alkalosis. So these people can start to have confusion, hypotension again because of the vasodilation. So in the a lot of times in the field, we're not going to be able to tell exactly what's going on. Just got to look at the contributing factors of what may be happening with that, and go from there. Bottom line is, if you're not sure, fall back on your training. How fast is somebody supposed to breathe a minute? Let's do that for them. What's their pulse ox reading? So you're not going to be able to measure CO2 in a lot of places unless they do monitor the EtCO2 part. So if the judgment seems to be cloudy or frustrating, fall back on your training. Hey, an adult needs to breathe this many times a minute. So, and acidosis can a lot of times kill you before the alkalosis will, and a lot of it through the respiratory in the field. So let's treat what we got in front of us. So these are just some processes that could cause cellular injury or damage. Hypoxia, that is the lack of oxygen. You have to have I think those that compatible with life is like 19.5% as far as oxygen, and below that it's not survivable. We breathe in 21%, and we give off anywhere from about 16 to 17%. So we're only keeping a small percentage of that, but that's what it takes to keep you oxygenated right. Ischemia is a lack of blood supply. You got chemical injury, that's poisonings, hazardous materials, infectious injury, stuff like pus or an infection that can invade the surrounding tissues and come around the actual wound. That can actually cause some types of cell death. Immunologic injury, things that will distort your immune system, for like certain types of chemotherapy or medications. Large amounts of steroids can make you immunocompromised. Physical damage, that's actual damage, primary damage to the cell itself. And of course, inflammatory injury. It's becoming inflamed for some reason or another. Inflammation is an overreaction of your body to an event. And a little bit is actually good for it, but then a lot of time it gets out of control, starts to spread. And that's when it gets bad, because it does alter the functions at that point. This is simply, it really, if you're able to see it real good, what it's showing is, like on the left is a normal picture of muscle cells. You can see in a few places, you can see like where a nucleus is surrounded by a cell membrane, and those borders are defined. In the right one, it shows where there's been swelling of the cells. They've been ruptured. the nucleus are just spread out in different areas. That's actually nuclear debris. They've been broken down. And what that happens a lot of times in like if you have a wound or something that's swelling and swelling up and getting reddened, that's what's happening. Those cell membranes are breaking down. Those nuclei are just becoming distorted all throughout, and you get acid and build up in there, and that's what causes a lot of pain and stuff. So they get spread out. That's what the cell injury looks like under a microscope. And even if this can happen to a point, if cells don't receive enough oxygen, they'll get to where they get acidotic, the cell membranes will break down, and it'll swell and rupture. So, and then toxic waste will build up in there. That cell will start to decay. It'll start giving off debris, waste. It'll start building up, become sore, and that's when you start seeing like the infection, like pus and things like that around it. So, and if left alone, it'll spread outside of just that cell and get into parts of the organ or get other healthy cells that are nearby. So that's what'll happen, and that's why it's important to get treatment for those. Now, common cause of cellular injuries, a lot of times it's due to they don't get enough oxygen in the air, or loss of hemoglobin, or cellular. This is the cell not getting what it needs and acting out, tearing up, dying, rupturing, not being able to carry on its function. So lack of oxygen, it's in the air that can't get to it, or maybe the air is getting in, there's enough oxygen, but for some reason or another, the hemoglobin is not working right, whether it be that it's being detached because of some type of carbon monoxide coming in. Even with the carbon monoxide poisoning, you got the right amount of oxygen, but with the carbon monoxide coming in as well, it just won't let it get on. So that way the hemoglobin is not able to function and get it to it. Or anemia, the number of red blood cells that are there to carry on the oxygen, you just simply don't have enough. Respiratory or cardiac issues, they've got emphysema, they got pulmonary edema. It's not able to let the oxygen cross over to get to the blood system. And the loss of some cytochromes, where simply a lot of time that's due to it can be due to a chemical effect or some type of poisoning that sets the at the cellular level off to where it won't function, or there's some hereditary factors that will not allow the blood to carry on like that. Some types of birth defects cause that. Now, chemical injuries, it can be, a lot of times it don't even have to be well known what the chemical is, or even know that it's there. So we all learn about the rule of thumb, approaching chemicals, hazmat areas, but some of these injuries can cause, like cyanide. What that does, it makes the cells starve to death from oxygen. It makes them to where they will not absorb any oxygen. So the oxygen doesn't get to where it needs to go, you die. Pesticides, a lot of times they release neuromuscular pulse blockers, and like an organ, if they're there to kill bugs or pests, it makes it to where they get paralyzed, they can't function anymore, and they die. A lot of times they quit breathing and stuff. Now, what this does is it actually releases a chemical called acetylcholinase. Well, acetylcholinase is what you got in your body already that makes you be able to store and remove oxygen. So what happens then is this blocks acetylcholine, is a shorter term for it, but it's better to use, that it blocks this from doing its job, so the oxygen's not able to get to where it needs. So pesticides a lot of time destroy these oxygen carrying enzymes, and that's the way that it works on the pest, and it can affect humans this way. And where would you see that? Maybe if I went on a call once where an organ man passed out under a house, and come to find out it was because he'd had some throughout the rest of throughout the beginning part of the morning, he hadn't been wearing his PPE and stuff like that much, and it wasn't a new guy. It was like a 20-year veteran, and he just got complacent, and of course he would treat that with some atropine and things like that. So, for example, lead poisoning. Lead paints have been banned in a lot of housing projects, a lot of housing development sites, because through the years, kids will eat that off and on through the years, or slow poisoning water systems can cause oxygenation issues, some neurological issues. The carbon monoxide is like talked about earlier, it simply, you can have 100% oxygen. You can have a 100% pulse oxygenation rate because the plasma and everything's got 100% oxygen in it. But the blood cells, the carbon monoxide will not let it attach to the hemoglobin in the blood, so the blood cells will die off. It's not getting where it needs to be. So, and other ones, higher doses of ethanol, drinking too much, CNS depression, and hypoventilation. That will cause chemical injury to the cells itself as well over time. People can die from a single alcohol poisoning. Now, infectious injury, these are ones that are from usually foreign material, from bacteria, fungi, or viruses, in other words, germs. The virulence is a term that measures the disease-causing ability of a microorganism. Like some things may be more virulent than others. They're saying now that this new COVID strain come out has a higher virulence than the previous one that we've been dealing with. They don't know if it's going to be as deadly or not, but it's a lot more contagious from what they're telling us. A depressed immune system, it's less capable of fighting off these germs. White blood cells release endogenous pyrogens. That means that they can, it lets these, supposedly they want to attack the invader, and viruses take over the metabolic processes of the host cell and uses it to replicate. In other words, what's happening, the virus takes over the cell, it says, I'm taking over you and I'm going to use you to get around. You're going to be my vehicle through this body so I can spread as much as I want to. And a virus has, for the most part, nucleic acid, RNA, and we think back about the vaccination for the COVID coming out, they've talked about how it worked as a messenger RNA. In other words, it sends a message to the RNA, says, hey, if you see this, don't listen to it and attack it. Some bacteria are harder to get to than others. They have like a protective capsule around them. That's why sometimes antibiotics, the first couple of days of an antibiotic may just chip away at the barrier. Somebody's like, well, I'm starting to feel better, but they've inactivated it, but they hadn't really killed it. And the same way a vaccine will work, it could work just opposite of it. It just makes it stronger to attack that antibiotic in the future. So that's why they need to be able to leave it in there long enough to let it work to get through the protective barrier. For example, men with prostate infections, instead of taking it's very, very, very difficult for medication to get inside the prostate, and they may have to be on what would, like for an ear infection, if they were on the same medicine, they might have to take it 28 days for a prostate infection because those cells are very well encapsulated and protected. That's one reason that sometimes prostate cells or cancer isn't discovered right away, because it is in a very protective environment. Inflammation, like I said, a little inflammation is not bad. But it's a protective response. It's where they have an injury. It's kind of like, all right, let's send in the troops. Let's get everything here we might need to deal with this. Think of it's kind of an elementary example, but think of like if you have a car wreck. Well, a car wreck. What happens when they have a car wreck? Man, you got police, got fire, EMS. You got a lot of like red lights around there, a lot of people going into action, and it does cause some disruption in the normal flow of things. That's kind of what inflammation is. It's sending all the help out and everything like that, and it does cause some damage and letting it happen. So a lot of these reactions, it could be physical, chemical, a microbiology agent. And how do you know this is going on? By the time they get warm around it, redness, that's the inflammation part. And it's everybody getting on guard to see what they need to do to compound this foreign body. With inflammation, people are going to they usually feel ill. Sometimes the body temperature goes up. And a strange thing about, and I hadn't studied Chinese medicine, but I do know that they believe that the body raises its temperature in order to combat foreign agents. Seems like in America or Western medicine, we do all we can to fight fever. Over there, they even induce fever in some people to try to fight it. So I don't know. It's interesting. So, but sometimes if the inflammation process is severe, people can get septic. It can cause some problems with what they call inflammatory response, to where it gets out of control. In other words, somebody that might have showed up to help in a good way has now started a riot or something like that. It starts to get out of control and cause damage. So we'll talk more about sepsis and SIRS a little bit later, but inflammation, a little bit to start off with, is not bad, but when it gets out of control, that's where a lot of the problems come from. Now, for example, if you look at this, you have a foreign agent that enters the tissue. Then you get the mediators of inflammation. You'll get like the capillary dilation that'll let the blood flow come back in. It'll be reddened. You have more blood flow, because it's also bringing in white blood cells, in other words, to attack the organism itself as well. Increased permeability, that's when those blood vessels start to break down. That the cells are starting to, some of them are injured and died. When they do that, they release acid. The membranes start to break down because they're getting more fluid and they're getting more attention, and it's what they can't handle. It's breaking down the barriers, the crowd barriers, in other words. So it starts to swell or get edema. So then they start getting these white blood cells that start coming in to attack, and the body reacts to this. Gets a fever. He starts having these white blood cells into the area. If bad enough, they'll leave the area, start getting into the rest of the body. That's when they start getting septic and SIRS, or systemic inflammatory response. On the outside, that's when you see the swelling, the pain, maybe a big whiteheads or something like that. Some genetic factors. Some people are born with issues that affect the cell problem or cell division, and sometimes they acquire it. They can something can interrupt that can cause chromosomal changes, like fetal alcohol syndrome. They can the baby's damaged by drugs or alcohol while they're in utero, and it alters the fetus's genes and their cells to where when they come out with some very physical and neurological deficits. So sometimes a gene can just go wrong, like even in the production process. For example, an anomaly would be like Siamese twins or extra limbs, things of that nature, just to have a very limited example. So that can, some things that not so pronounced would be like atherosclerosis, obesity, sometimes diabetes. These things are a lot of times genetic factors that are inherited that we may hear about more often. Nutritional imbalances, obesity, malnutrition, excess or deficiency in vitamins. Now, if you take, a lot of people waste so much money on vitamins, because if you take any more than what the body uses, for the most part, your body doesn't store most types of vitamins. And anything you take over what the recommended daily allowance is, it's just going to be gotten rid of. So you're really wasting a lot. There's really no use to take 2,000 milligrams of vitamin C a day, because your body's only going to keep anywhere from 75 to 100 milligrams. That's on a daily use. Same way with minerals. Your body's going to get rid of what it don't need. And the way it gets rid of it, for example, like certain type of nitrites or oxalates, your body may say, well, we're not putting it in the blood, but we're going to store it. And the kidney's like, well, okay, we'll just keep it here. And that turns into a big kidney stone. So there's different ways that those minerals can manifest if they're not used. Some physical conditions that damage a cell, of course, the obvious, too cold, too hot, radiation, And for the most part, it's how long it's exposed to those variants, to those problems. Now, a term called apoptosis. Let me see, did I leave one out? Apoptosis. No, that's right. It's normal cell death. In other words, cells are meant to be created, they live a while, they do their thing, and they die off. But that's the normal way it's supposed to happen. Some cells die out a lot closer than the others. So it's pretty much programmed into them to do this. They do their function, tissue growth, and then they die. But sometimes, unlike in a case where it's from a process, the DNA and the proteins, they allow their cell, they share their cells. Okay, I'm dying here, recycle me. And other tissues will use that as well. So areas to where this happens normally, it usually don't show a big inflammation process. It's when other factors get involved with homeostasis that cause that. So, but an injury, cell injury, or something like that can speed up the process to where cells die and are recreated or absorbed or simply just decay. So the that's why, like some chemical injuries, like sunburns and things of that nature, or chemical exposure, may cause the cell to get to start mutating or growing or healing at an abnormal rate. And that's when you see a lot of these like chemical exposed cancers and things of that matter starting to go on. So the way this looks at it is you got a normal cell and it's acted on by an outside force. And then for some reason or another, it becomes an abnormal cell. Now, if it's through normal factors or things like that, for the most part, it should become the immune system can take a hold of it and get rid of it. However, sometimes the immune system can't control this, and that's why exposure to certain cells or some other cells, especially from a outside source, cannot be dealt with internally, and it may become cancer. Necrosis, that is when something begins to rot. It usually changes colors. It's tissue death. The result of a lot of morphologic changes. It can start to spread to other tissues around that and release toxins into the body. Now, sometimes it'll be a small area, like you've seen like a toe go black, or a certain area of skin go black. A lot of times it's in the extremities, distal extremities to start with, and it can get worse. And it can be caused by like ischemia, poisoning, or something like that decreased the blood flow to that area long enough to where it would die. And of course, direct physical injury. Something got hit so hard that it destroyed the physical characteristics of the blood vessels, the cells, and it caused them to release so much of free radicals and things that they die. Now, derived necrosis, this includes cessation necrosis, like it gets cut or to spread that way, dry gangrene, fat necrosis, or liquefaction, where things actually become liquid and ooze out. A lot of times you don't see that until somebody starts to decompose. Now, talk about perfusion. Hypoperfusion is another name for shock. Now, shock, for example, hypoperfusion is the inadequate tissue perfusion when it's below normal. So perfusion is simply getting the oxygen and nutrients to where they're supposed to be, not only getting them there, but taking out the trash as well. They got to be able to get rid of the waste as well, because building up a waste is just as deadly as not getting someone to bring the oxygen in anyway. In order to have adequate perfusion, adequate circulation, you got to have three things. You got to have a pumping heart, you got to have an intact vascular system, and the appropriate amount of blood, of fluid. You got to have those things. The disruption in either one of them will cause the others to react and work harder to try to make up for it. You start losing blood, the heart is going to pump harder to make up for it. It's also going to make the blood vessels constrict to make up for it. If a disruption in either one of those will cause inadequate perfusion. If it's something to do with the heart, the poor pump, you got to think cardiac shock. If it's due to a blood loss, it'll be hemorrhagic hypovolemic, and we'll get into that in just a minute. But hypoperfusion is when it's simply not meeting the needs that the body has as far as goes the delivery of oxygen and nutrients. It causes a big disruption in homeostasis. And the response to that is response to hypoperfusion, low blood pressure, perfusion not getting to where it needs to be. Your body will start to release catecholamines, which is epinephrine and norepinephrine. Now, what does this do? Remember the flight or fright response. Epinephrine causes the heart to beat harder, faster. The force of contractions increase, and also vasoconstriction, constriction of the blood vessels will contract as well. This increases the systemic vascular resistance in order to make the blood pressure to go up with to meet those original needs. Now, the longer this goes on, the longer hypoperfusion occurs, the heart will start to get stressed, and then the heart will start to eventually give out because epinephrine and norepinephrine only last for a little while. That's why when someone gets an adrenaline attack, usually you just have this big rush, then it's over with, and you're left with complete exhaustion. I mentioned the cheetah the other day, the wildcat in Africa could chase after antelopes or gazelles, whatever they eat, for about 70 seconds, and then it's over with. If they don't catch it in that amount of time, they crash, and it takes a while for them to build back up to where they can do it again. So what happens here is that starts to become shock, and that is it's inadequate tissue perfusion, especially with the delivery of oxygen and nutrients. These other mechanisms that kick in, increase heart rate, increase vascular constriction, can only last for so long, and then it'll give out and it'll be decompensated. So you start to have impairment in cellular metabolism, inadequate tissue perfusion, and if the body's compensatory mechanisms are, remember it this way, if the body's compensatory mechanisms are sufficient to stabilize the patient's condition, the shock is called compensated shock, but it doesn't last long. If it continues and overwhelms normal compensatory mechanisms, they will deteriorate, and it's considered decompensated shock. That's when they start to get hypotensive. Now, once they start to get hypotensive, they're no longer compensating, and you're starting getting into deep shock. Now, shock can, there's a couple ways that it can happen. It could be due to inadequate of central or peripheral circulation. And what is central? That's simply the heart. The heart can't maintain enough blood to circulate through the body to get where it needs to be. That means the pump itself is malfunctioning. The other one that goes along with central shock is obstructive shock. Now, what causes that? For some reason or another, it's not letting the heart pump the way it needs to. Is it stopped up, or is it completely blocked? Do you have a big tension pneumothorax that's causing so much intrathoracic pressure that it can no longer pump against it? Or do you have a large blood clot that can't get past the pulmonary artery in order for the blood to circulate and get oxygen? That is a form of obstructive shock. Cardiac tamponade. You get enough pressure inside the pericardium around the heart where it can't beat anymore or fill up with blood. That is obstructive shock. So that once that starts to set in, that can be pretty deadly. On the left, you see this is probably taken post-mortem. But on the left is a picture of the heart, and the sac is swollen up because it's full of blood that it can't beat anymore. That's a pericardial tamponade or cardiac tamponade. And the other day when I said about the heart being surrounded with fat tissue, well, you can see there what I'm talking about, all the yellow around there. To the left of that blue section, you see some spongy type material, kind of pink. That's lung tissue. And you can see how it's divided up into smaller and smaller and smaller clusters. So, but it looks like they've had to crack this chest. You got irregular borders. The bottom right corner of that first left picture, you can see where the ribs been snapped. So they've had to cut in there to do this. Well, here's after they relieved the pressure inside the heart. They've cut away the pericardium, and there's you see at the bottom part of that picture how thick that pericardium is. I don't have anything to scale it by, but it looks like it's probably a millimeter or two thick. So you see how that surrounds it. It keeps that blood in there to the heart cannot pump against it. I don't know if any of you deer hunt or anything like that, but if you do, you're cleaning an animal. Then if you hadn't destroyed the chest too much, it's a perfect opportunity to look at the way those organs function together and how they actually hang there in a pendulum type motion. The what we're looking at on the left is this is the aorta after it leaves the heart. So it leaves the heart. You follow it around like a cane. It goes to the rest of the body. You know, it's got those three vessels on top that goes to the head. The one that goes to the first one you come to goes to the right side of the head. The second to the left, and then the left one is the far right one goes to the left subclavian artery to the arms. Now, what happens here sometimes is you see this has a tear in the aorta. It causes a proximal and a distal dissection. A lot of times that will rip all the way down, and you can see the pink portion on the outside of it where those arrows are coming out. Remember that artery that I showed you that had those multiple layers around it, it won't allow it to bleed to the outside, but it'll start swelling under that. Now, the heart is hanging there like a pendulum, so sudden deceleration activities or trauma can cause the heart to actually pull away from that, and the weight of that can actually tear the aorta. I've seen it several times, and a lot of times they'll hold on for a little while, and then when they crash, it's so quick you can't even keep up with it. So that can start to tear and swell all the way down. Now you see on the right side, you got a tear in where the descending aorta starts, and it starts to swell up around that. It's forming an aneurysm is what it's doing, or just a dissection, to where the blood is leaking out of the main artery wall, and it's getting under those other layers, the intima and the media intima and all of that in there to keep it together. Now that'll start spilling all the way down, and these patients can start going into shock quickly. And if that ruptures all the way, then pretty much it's over with. Now, I gave the example the other day of this lady she was breathing 33 times a minute. It's the only symptom that she even denied being short of breath, but her body said, oh, there's something wrong. Breathing 33 times a minute, pressure and everything was normal, and it was normal all the way to the hospital. And when I got her there, she coded and died instantly while I was giving a report. And they seemed to think this is what was going on. It was holding till the last minute. The body knew that something was wrong, so it was trying to breathe harder to make up for that. And once we got there, it must have went ahead and ruptured, and she lost all of her blood volume into the inside of her cavity. Not much anybody could do about it for that. Peripheral shock is that type of shock that takes place outside of the central area of the heart and the main major vessels. It's going to be like what happens maybe out into the away from the midpoint. And there's two types of that, the exogenous and endogenous, which exogenous means that something caused from the outside, a gunshot wound or a stab wound or a large laceration. Endogenous means it happened on the inside, like a ruptured aneurysm or a gastric ulcer or something may have ruptured, or an esophageal varices may have ruptured. Distributed shock, that is when the dilation of the blood vessels remember we have to have the pump, adequate blood volume, and now this is an intact vascular system. Now the vascular system can cause you to have shock even without being cut. And what that is if you think about if you have a pipe or something of that matter, and you've got pressure going through it, and if you make it bigger, it's going to lose pressure because it has nothing to beat against it. It loses resistance. So distributed shock, that's when the widespread dilation of resistance vessels loses its able to have compliance. For example, this will happen a lot in sepsis. The blood vessels will dilate, their membranes will become permeable, the fluid will leak out, will leave the vascular system and not be able to maintain a pressure. The other thing is this will happen also with anaphylactic reactions where the blood spills out of the capillaries and spills into the skin. It also happens with neurogenic shock, which is where the blood vessels have to constantly receive messages from the brain that tells it to maintain constriction or relax. Without that signal to tell it to react, it's going to automatically dilate. So like if you have a severed spine or uh, an inflamed nerve that's not being able to send that signal to the blood vessels, the vessels are going to open up and dilate. The pressure will drop. The heart rate will usually stay the same, because if that nerve pathway is cut, it's not going to be able to get the sensation that, hey, something's wrong. So they will have a low blood pressure in spite of a normal heart rate, and their skin will not become diaphoretic and pale. It may become pale, but it will not become diaphoretic. A lot of time it will not lose temperature. So that's what's odd about the neurogenic shock. The anaphylactic shock is a type of third phase shock, we call it, or not being able to maintain the membrane stability. But anaphylactic is when histamines and proteins are released to fight off an antigen, say like a bee sting. That has that causes the vessels to dilate, and it will cause the blood pressure to drop. Now, a lot of time with anaphylactic shock, you'll have wheezing, you'll have a rash, which is really part of the allergic reaction. Now, what differentiates anaphylaxis or anaphylactic shock from a bad allergic reaction is when the vital signs start to get affected. That's when somebody goes from being stable to unstable. So if you've got someone that has a normal blood pressure, they may be wheezing and have a rash, they are still having a bad allergic reaction, and they're on the borderline of anaphylactic shock. But once the vital signs start to fail, the blood pressure drops, then they are going to be in full-blown anaphylaxis. Septic shock is also a distributive type of shock, but that happens with because of the infection is getting out of control, and it causes the blood vessels to dilate, the capillaries to not be able to hold their containments in, and it starts to spread, and it can become systemic throughout the whole body. And once it gets to a certain point, that is very hard to turn around. We overlook sepsis so much in the field, or maybe we just see the very early signs of it, and a lot of times it won't develop till later on. But people don't always have to have a fever to be septic, especially with older people when their temperature relating or their temperature regulators, the hypothalamus and such, is not functioning that well. Someone can have a normal or even below normal temperature and still be in septic shock. Neurogenic shock is also falls under the distributed shock that we just talked about, that's due to damage to the nerves or spinal cord. It's a spinal cord. There again, the nerves do not receive the signals to maintain a blood vessel dilation in order to keep resistance and pressure up. So when it stops receiving that signal, that's when it starts to dilate. The things that can cause like the cardiac shock, reduced cardiac output, whether it be the heart failure, the heart's not working right, it's backing up. It's usually caused by an MI, myocardial infarction, or hyperventricular hypertrophy, so where it just simply does not work right. Or it can be because of cardiac tamponade. The cardiac output is not what it's supposed to be. Circulatory insufficiency, there again, the blood vessels are either occluded, they are torn, or they've over dilated. And a rapid heartbeat, simply the heartbeat will be too fast in order to fill up with blood, in order to pump it out to where it needs to be. That's why I like with PSVT or supraventricular tachycardia or VTAC with a pulse, the heart is beating so fast that it cannot fill up with blood, and they will start to deteriorate. That's when you have to shock it out of that in order for it to reset and gain where you're able to get back into it and let it reset, hopefully in the right rhythm. Now, what are some one of the best ways to start checking for that? Capillary refill Prolonged capillary refill is one of the first indicators of delayed perfusion. Now, a lot of time you'll see the capillary refill before you'll start to see blood pressure falling, simply because the big arteries to where you're taking the blood pressure still may be getting perfusion, but it may have already started to shut off stuff to the distal phalanges. Modeling, pallor, peripheral, or central cyanosis, that are going to signal shock. Now, I had a guy the other night that was in big time CHF, congestive heart failure, and he was mottled all over his body. He was so diaphoretic when I put the EKG pads on him, they just simply slid off. They wouldn't even stick. So, but modeling that showed that he was already, his blood pressure was actually high, but a little while later it wasn't. But when the modeling, that means that, hey, it is shunting it away from the skin, the outside areas, and getting it into where it's needed most in the central circulation. So the multi-organ dysfunctional syndrome, multi-organ system failure, that is something you may hear, or another short term for it is called MODS. But that is simply, it's a progressive condition that a lot of times forms in critically ill patients. You probably ain't going to see it much in the field unless you go pick up somebody that's been home or sent home or something like that. This usually happens in ICUs where they see this at. It starts when two or more organ systems start to fail at the same time. The mortality rate, they say it varies, but for the most part, it is pretty deadly once it's to start, because a lot of times it starts a big myriad, a progressive type of syndrome that just doesn't quit. It occurs when an injury or infection, it can happen from an infection as well, triggers a massive systemic immune inflammatory and coagulation response accompanied by the release of toxins. So this will start to have little blood clots starting to form in different areas of the body, and these blood clots will stop the blood from getting to where it needs to be. Some of these people have these big rashes or big areas of mottling or discoloration, and that's because these little emboli or blood vessels or clots are starting to perform everywhere, and it'll kill the organs because it will not allow the blood flow to get to them. Now, you'll have like primary, which is a direct insult, such as a pulmonary contusion. That is something where it actually hurt at. And the secondary is usually slower. That's when the blood clots start to form in those other areas, and it decreases the perfusion and matters of that. And like I said, when I tell you a story, it's an example. Young female in her 30s, she had I picked her up because she simply had abdominal pain, and she'd been waiting all day to call because she's waiting on her kids to get home from school so she can have a babysitter. Well, when they got there, they called, and I went and picked her up. Severe abdominal pain. You could tell she had such abdominal contractions, it was unreal. I mean, it looked like a basketball rolling around in her stomach, the way her muscles were contracting. A lot of stuff that could be in there. So I started an IV on her, gave her some Zofran and gave her some pain medicine. And come to find out, well, later they said that she had her intestines had actually twisted on the inside, caused a lot of blood flow restriction, and her gut was dying. Well, they got her to a big trauma center, and they done the surgery, reversed everything, and she was on Facebook a couple of days later, from what I was told, because we had had somebody that knew her, and her body all of a sudden started having those enzymes, and cell damage and stuff had already took place that was irreversible, and it ended up killing her. She died the night after she'd been on Facebook that morning because they said her multi-organ system failure. Once that the gut was released and some of those poisonous products got loose in her body, it set off what they call a big-time systemic inflammatory response, and it killed her. And they said that her lactate was through the roof, which bad lactate can simulate sepsis, which stimulates that all that lactic acid is breaking out of the membranes and stuff. So, a lot of time we see that. Hey, I've seen people 2 weeks later from a traumatic car wreck or something like that I had seen, and then you read about them in a paper a couple weeks later. So that's what's going on with them, this multi-organ failure thing. So what the body does is when it starts getting invaded with injuries or illnesses, your immune system is supposed to help defend against these foreign substances. And it does it, but like I said, the inflammatory response, which initially is to get things under control. However, things overpower it and it gets out of the way. A lot of times there's some anatomic structures that are there, anatomic structures that are there to help do that. Like your skin is one of them. Your skin is probably the bigger one. You've got the cilia, the hair-like structures inside of your nose and your mouth, in your lungs that sweep products out. You got acid in your stomach that should kill a lot of foreign invaders. That's the physical part of it. Natural immunity is what's there when something first happens. It should be something like it works directly against the invading microbes, whether it be an allergen, a bacteria, or a virus, other types of foreign bodies, and abnormal cell growth. It even tries to work against it. That's when your body might start acting funny, or a fever. Something is a response that something's going on. So what happens then is you got this internal response that probably starts first, and then that's what's naturally there, natural immunity, and then it probably starts getting help from an acquired type response. So the cell walls then activate the initial system. They start to get a lot of time reactive. They get hyperreactive. They may even start to get to where they lose their protection with permeability. Then you start to get a little chemical now. Then these leukocytes start to develop to fight the infection, and they starting a cascade and letting off different types of natural antibodies. And some of those are like, you've heard of eosinophils, and that'll cause that. A lot of times you'll see that in allergic reactions. One's face will get red and irritated, swollen and puffy. Neutrophils a lot of time will be in the the CNS fluid, some type of infection of the brain or spinal cords. Sometimes they won't actually be able to see, if they do a spinal tap, they won't actually be able to see the invading bacteria. But a lot of times they'll look for an antibody that's formed. Like if neutrophils are not supposed to be in your CSF, but unless there's an infection. So when you see neutrophils, which are bigger cells than the bacteria that's causing the meningitis. So when you see the neutrophils show up, you can bet that there's something going on in there. So a lot of these tests look for the antibodies, but like monocytes, lymphocytes, macrophages, that are the big ones. They actually engulf it up. If you think like the old Pac-Man movie, things of that matter. Then it gets down in where it talks about B cells, helper cells, T cells, killer T cells. Like a lot of times people get this HIV or human immunodeficiency virus. That is where the body had stopped making a lot of these antibodies. And like AIDS and HIV itself, that virus is not what kills you. It's just that it can't fight off everything else. It's everything else is allowed to kill you because you don't fight it off. For example, every day we have certain antibodies that we come in contact with, and that we're able to, antigens that we come in contact with that we're able to fight off. Someone with a compromised immune system is not. I had a girl one time that had, she told me she's got meningitis, and everybody freaks at first. She had a temperature of 106, and she's like, I've got Cryptococcus meningitis, which I knew was a fungus. And she told me, she said, I've got AIDS. She said, you can't catch this. And, I did some research on it afterwards because we took all the precautions. But sure enough, she had AIDS, which means she wasn't able to fight fungal infections. And it was actually a fungus that had got inside of her brain, and it wasn't her first rodeo with it. But normally someone that doesn't have a compromised immune system is able to fight it off. So that's why it was able to get at her. She had no T cells left. But that's what's going on all the time inside of an infection. That's why it makes you feel bad, because it's hard on your body as well. And your body's reacting up. Your body's working out to fight something when you start to feel bad from it. So this little quick diagram here, simply that when you get the antigen antibody, they get together and they form a complex. And as you can see how all of this stuff might let go. The enzymes, the outer membranes, they try to form a barrier, but then again, they start breaking down, so it's able to penetrate the cell. You start getting these antigens and cell bodies start to clump up. That's when you start getting inflammation. The bacterial cell will a lot of times swell and bust open, then it spreads to the other ones, and then those white blood cells start coming in, the different types, and even the big phagocytes, they are the ones that try to eat it up. But oftentimes they get overwhelmed. Overuse of antibiotics has caused some of these microbes to get to the point to where, when they see that antibody coming, they give it a big power punch and kill it, so it doesn't work against it. So that's why some of the antibiotics don't work anymore. A lot of things are resistant to it. So antibodies are pretty much, they attack these invaders, and they make them more available they help them locate. They kind of are tattletales. Hey, there's one there, so that the cells or the immune system can attack it. So they're like the big tattletales of this. Sometimes when what we call mediated immunity is when there are certain childhood diseases that people get that those antibodies will recognize forever, and they're able to attack it when it comes along. So that's why they try to induce these immunity programs, like immunizations is a secondary backup. But as far as immunity goes, you do have some natural immunity. However, unless it's suppressed, then that's when people are going to have issues with it. It's pretty complicated looking one, but it just simply shows that when these cells all get together, that they start to they recognize the foreign invader, and they communicate to like the next stage is the lymphoblast. They start dividing with extra strength and start to attack it. They form a memory cell. It's kind of like where it remembers. It's kind of like what immunizations are meant to do. It will cause them to remember that attack or that invader, to where they can already get in shape and be prepared for the next one. It's simply like keeping ammunition or armor things in an armory to keep aware from it. Now, a lot of times when they talk about antigen binding sites, all of these cells have a place to where an antigen can attack certain cells. Like there's certain antigens that's going to attack a neurological condition, and as you can see, like, or some are only going to mess with the heart, some's only going to mess with like the lungs or the kidneys, and that's because that they actually like a set of let's see, what's it called, Legos. You can see on the side there, the antigen is only going to fit certain receptors of what it can attack. That's why some invaders won't. There's some bacteria out there that will not cause, perhaps, say, a lung infection, but they can cause a kidney infection because they're engineered for that. Now, inflammatory responses that's how these cells of the body respond to outside invader. When it's acute, that means that it happens real quick. So a lot of them happen because something caused from the outside, as far as an infection or an injury, or even a type of an allergic reaction. During these reactions, these cells can become, they do get overreactive. They get hypersensitive. Hypersensitivity is the word that you've heard before as far as allergic reactions and stuff goes. And they they'll give off fluid, because remember, what they're producing on the inside is far greater than what their membranes is able to keep. So that's when you start getting swelling. Now, when the body gets overwhelmed with these responses, it's kind of, your body, if you think of it as a household, gets very disrupted with it. For example, histamine, for allergic reactions, and serotonin, they increase vascular permeability. That's what comes from a lot of these mast cells that are affected by these invading materials. They'll start causing vasodilation. They'll cause your bronchial constriction, where you'll start to hear wheezing, and your body will say, hey, I've got food in it, I don't need it. That's when they'll have nausea and vomiting. Another reason for that is those sphincters will relax and your body can no longer, your smooth muscles will contract, and that's why it'll a lot of times vomit with these. So there's some of these responses are caused by an infection, which is what sepsis does. And there's also can be an acute reaction called SIRS, or systemic inflammatory reaction, which looks just like sepsis, but it just doesn't have an infectious process. Now, all of these terms you're not going to have to remember, but just there's a lot of them. It's just mainly for FYI part. But it talks about these neutrophils they arrive at, if you think of it as they've had an event, they've got a big a fight going on or an invasion. So these neutrophils, they have several different functions. They arrive there where the tissues are needed. They start doing an intravascular phase and an extravascular phase, which means that they start to form on the outside of the vessels, and they're also on the inside of the vessels. Now, what does that do? That means that that membrane is breaking down, so you're going to start having fluids swap back and forth. You're going to start to have swelling. So during this phases, these leukocytes travel outside of the blood vessels to the site of inflammation, and they fight the organisms. In other words, they're let out of the boundaries. They're released from the ship, if you will, to go fight. And when this is going on, it's noticeable to the outside because that's when you have the swelling and the pain. And sometimes you could have this going on inside, like a knee or a lung or a bowel or something like that, where you can't see it on the outside, but you'll have these other signs and symptoms of an infection. A lot of times they can't really pinpoint an infection, but they pick up these, in blood work, they pick up these other components. And that simply is like, okay, well, you got an infection going on, so we're going to give you an antibiotic or broadcast to effect. That's kind of the way that's working, because it's getting into the bloodstream. Hey, we got a problem going on. The way things should heal, as far as normal wound healing, is damaged tissue. They want to repair that first, barring any type of infection. That's when cells begin to divide and form new ones to close the gap, if you will. And then it's got to remove the damaged part, get it out of the way. It's got to, as far as tissues to normal state, like if you've cut yourself, you see a scab form, and it's awful tempting. A lot of times people keep pulling the scab over, but that's what's happening. It's reforming it to a normal state underneath. It's kind of putting a tent up or a roof over, a temporary roof over the work site so these guys can work. So when we talk about the wounds, a lot of times heal by primary, secondary, and tension. The primary occurs in clean wounds with opposed margins. That means they're equal, they bind up. If they're irregular or very far apart, that's when they might have to do suturing. Like if you do have a large open wound that's not sutured, it has to start at the bottom and start building cells and walls and joining all that back together, back up toward the top. And those are more apt to get infection. They get infected in there because they can get. That's one reason they suture large wounds, not only to make it look better, but they need to close it up to protect all these other foreign invaders to get in there from stopping this normal building process. In other words, when you sew something up, you artificially put a roof over the work site. So, but some things that will cause these problems, or that will shut the work site down, there's infection, inadequate blood supply, foreign bodies. Some things that may cause systemic factors with it would be like, for example, someone with a diabetic, and they got someone's a diabetic, they have slow wound healing. not keeping it clean or covered, AIDS, corticosteroids, they slow wound healing. They certainly will. They'll cause blood pressure, blood sugar to rise, and they will slow wound healing if you take a lot of blood pressure medicines. I'm sorry, steroid medicines. That's that because there's not a lot on there that could really help you. But hypersensitivity is some things people may have individually. Hypersensitivity is simply an over response to these issues that probably really didn't have to happen. But like an allergy, something that is allergic, that is a hypersensitive reaction to a part. The autoimmunity a lot of times has antibodies or T cells that can work against the tissue of one's own body. Some people have an autoimmune disorder and they can overreact to the point that it can cause some near life-threatening conditions. Like an allergic reaction is an immediate hypersensitive reaction that usually occurs in response to a stimulus, and the degree of severity varies. When it's cytotoxic, that means something within the cell itself. Cyto means cell. That simply means something inside the cell itself can cause it to destroy or be destroyed by other antibodies. For example, and like a tissue injury can be caused by immune complexes. That is a type 3 type injury, like serum sickness, single exposure to an antigen. Sometimes it can be from a big joint reaction or arthritic reaction. And a delayed reaction sometimes there's hypersensitivity and a cell-mediated cytotoxicity. That means that can happen days or several days later after an exposure to where that's happened sometimes post-anesthesia, things like that, to where they have an exposure and there's not an immediate reaction, but it may occur later. They're usually not deadly, but they can show some type of a response later, and it may be hard to pick up from what it is. Let's see. Some factors that contribute to disease and healing process and immunity. A lot of times genetic factors. Well, my grandmother had diabetes. This is something that's going to contribute to your ability to heal, or if it's passed on to you. Some things that are genetic, you can't do anything about. Environmental factors. Well, we lived next to this factory for years, and all this smoke kept blowing on us, and now we all of our kids were born with 3 eyes. That's just. But environmental factors, things from the outside that can contribute to disease. Asbestosis. You see a lot of those commercials lately. Or mesothelioma. Age-related factors. The older you get, sometimes the more you can't handle certain issues. So your immune system deteriorates. Your cells are not able to fight off things as it once was. That's why older people tend to get heart disease, cancer. Sex-associated factors, for example, like more women are prone to some types of illnesses or headaches, or for like, men are not going to get ovarian cancer. Women are not going to get testicular cancer. More men, they used to say that more men had heart disease than women, but however, that is been proven to be false. Back to uncontrollable factors like genetics, race, influence of your development of the disease. You can't do anything about that. Hereditary, as far as heart disease goes, is a big factor. If you see someone that is having a heart attack and they seem to be young, if you ask, they're going to have a real close relative that had a heart attack as well. I've seen a 31-year-old with an MI, and he said, yeah, my dad died when he was 32 of a heart attack. And this guy did okay. But a lot of times, if you've seen that, these people have heart attacks in their 40s and 50s. If you ask about it, a lot of times they had a direct relative that had the same thing. Some things that we can control. Some people look at them as bad habits: smoking, drinking alcohol in excess, inadequate nutrition, lack of physical activity, and stress. I know in EMS, none of us see those things, and we don't participate in any of that stuff. But I know some people out there that work 48, 72-hour shifts. I can't do that. That's why I work 12s. But when they do that, pretty much you eat what you can, where you can, how you can. And if you've been up running for 48 hours on your day off, guess what you're going to do? So that's things that we can control as much as possible. However, that's things that maybe we can try to make modifications somehow. Says, well, I'll just stop drinking at work and only drink when I'm off, or maybe things you take to work with you would help your nutrition some. But it's so easy just while you're sitting at the store posting to go in and get a bag of, I know my vice is Cheetos. So risk of particular disease a lot of time depends on a certain age. It's kind of like cardiac disease usually takes place later in life. So does some of COPD and things like that. And then there again, the sex part is something that you can't have anything to do with. All studies of disease consider disease rates and disease risk factors. Now, what is in some areas, some diseases are more prone than prone to others. I was raised in the eastern mountain or hills of Tennessee. My family come from coal miners up in Kentucky, and my grandfather died at the age of 54 of black lung disease. He was a coal miner. And I picked up a hobo on a train once in New Orleans, and his history was he had black lung. I said, man, where are you from? West Virginia, Kentucky? He said, how'd you know that? So a lot of time, environment areas and things like that can have an effect on certain diseases. So some non-causal factors, the risk associated with disease, but not a direct cause, kind of like being in a certain location for a long period of time. So, and then not all disease kills people. When it talks about prevalence and mortality of disease, some of them have a bigger, like look at the COVID right now. There's not a lot out there because this book is just now being written. So hopefully we'll look back in 4 or 5 years and remember this as something that we adapted and overcome. Now, genetic disease is passed through generations, of course, and some people say, well, it skips generations, but there's really been no proof in whether something skips a generation or not. But it's some genes can be inherited, some can be dominant or submissive to another gene. Like, for example, spinal bifida is a type of disease that some people can pass on and get inherited. And it's usually because of one that gene has been dominant, and it shows up later on. Another one is like cystic fibrosis, or there's one called Huntington's disease, which is it's a neurological disease. It causes later deformities, spastic motions, inability to speak right, and that can show up in like DNA tests, 20 years before someone gets that type of disease. Cancers we talked about before is where the cells divide very erratically. They do not take in consideration the cells around them. They start to spread to the point to where they become invasive of a functioning organ or system. The breast cancer is one of the most common type of cancer among women. Colorectal cancer is starting to now. It used to be just men. Now it's starting to show up in women and men and women about the same time. So why is that? Is it they're taking a bigger role in society or something like that? It's I guess it's yet to be determined. But and then diabetes is another one. It's one of the most significant endocrine diseases. Type 1 diabetes are the ones that have to have insulin. They're more prone to ketoacidosis, which means they have ketones in their blood when they get acidotic. Type 2 can also get acidotic, but usually when they get acidotic, they have no ketones in there. You've got DKA and non-keto type acidosis. And they really can't determine that until they do the blood work on them, but that is two different factors that play into that. Some hemolytic disorders that are passed on is we've heard of a lot of time it's because the red blood cells get destroyed. Hemolytic disorders, it's in a type of anemia. These blood cells are destroyed. Also, it's because of the RH factor in the blood transfusion reaction. It can react and the blood cell turns on itself. It gets worse when they have infections or chemicals, like people that's worked in the oil field and things like that, especially around H2S facilities. They start developing benzene poisoning, can start destroying the blood cells and causing this hemolytic anemia. Hemophilia is an inherited disorder, and it's characterized by the blood's inability to clot. It's excessive bleeding, and they can, bleed to death. There's a lot of jokes going around about stuff like that, which is it's. I guess they've never known a hemophiliac to do that, but I remember one of the famous ones they had a long time ago was Ryan White, back when HIV started becoming popular. And there was actually a law written because of him called the Ryan White Act that has to do with training and standing up people with HIV and AIDS. And hemochromatosis is an inherited disease where people simply absorb more iron than it needs, and too much iron can cause problems with the liver, spleen, such as that disorder. So cardiovascular disorders, cardiomyopathy is where the heart muscle gets so inflamed and overworked and strengthened, and it gets large to where the ventricles cannot accommodate the appropriate amount of blood it's supposed to. Mitral valve prolapse, that's when that valve does not, that's the valve that's between the left ventricle and the left atrium. And when that valve does not close like it's supposed to, when the left ventricle contracts, it goes back up into the left atrium, and they lose that much perfusion getting out into the blood. Coronary heart disease, it's simply, they used to call it heart of the arteries, but that's when plaque starts to line the arteries, and it restricts flow going to the rest of the body, the lungs, the brain. It's a reduction in that because of narrowing of the blood vessels. Hypertension, which is high blood pressure, that's when that can be caused by a couple things. You've got an electrolyte imbalance where you keep a lot of sodium and stuff in the blood, which absorbs that extra fluid. You also get sometimes where the vessels, you're under a constant release of catecholamines, causes the blood vessels to stay constricted. And there's times to where when the heart just pumps too fast, and they usually give beta blockers and things of that nature to control that. And another one is stroke. You got two kinds of strokes. You got hemorrhagic strokes, and you got ischemic strokes, where there's a clot that's blocking the blood from getting a part of the brain. And of course, hemorrhagic stroke is when someone bleeds out into the brain tissue. This is just if you look on the left is normal heart function. It shows the ventricles. The left ventricle has always been a little bit thicker than the right one because it has to pump the blood the furthest. So if you look at this deal here, it has to do with, say, like probably aortic stenosis or hypertrophic cardiomyopathy, which means that the myopathy means that the heart muscle is swollen, reduced capacity. So if you look at the one on the left, you see that the blood flow is going through the aortic valve to the rest of the body. If you look at the one on the right, you see where that hypertrophy, which is increased thickness and increased size of the heart cells, that is really obstructing the blood flow that's getting out and going up into the aorta. So you can see where that can cause a big problem as well, and that's caused over neglected hypertension, or could be from a heart disease or some type of a heart infection that's caused those cells to get to that point. When it gets that's a lot of time it's irreversible. It has to be supportive care. Now, this is like kidney stones tend to be hereditary. This is a kidney stone, and what it's showing is that stone, those oxalates and those deposits. You've got all the little tubules, the little branches inside the kidney that actually formed inside the kidney like that, and it filled each little gap to the point to where I guess they had to remove it, or if they passed that, man, more power to them. These on the right hand side, if that is, it looks like that is probably 5 centimeters. And the reason I say that is you got like the big calyx here on the left hand side. It looks like a horn that goes into where the kidney dumps out, and the rest of it looks like it fills the North Pole and the South Pole on the way down, with all the little tributaries on the way in. So that's one big stone. I've had about 12 myself. They're no fun. Now, some gastrointestinal disorders, because of malabsorption, there's a reason people can't absorb nutrients like celiac disease, Crohn's disease, colitis, things like that, that will not allow the body to absorb. Gallstones is another one. Obesity, that occurs when anytime there's a BMI greater than 30. Then you got morbid obesity, and then overweight is considered 25 to 29. And there's a formula to where you can figure that out. Most of the time, it's just better to pull out an app and be honest with yourself to see where you fit at on that part. Some neuromuscular disorders that hereditary. I hit on a couple of these earlier. The Huntington Disease, which is a very, very, very sad disease. If you see one get to that point, for the most part, they are fully cognitively aware of what's going on, but I've seen them where all they can do is sometimes just scream and holler, and they get these. It does turn out to be a deadly disease, but it's very sad. I've had to go get people and take them from the home and put them in places that had it, and they'd fight you the whole way because they knew what was going on. But you're able to pick this up with a DNA test years and years before it happens. The thing about it is there's not anything they can do about it. Muscular dystrophy is where the muscles deteriorate over time, where they become unfunctional. Multiple sclerosis. They're making some headway with multiple sclerosis. You see some people that are in and out of remission a lot, but a lot of people live for years with this stuff. And of course, there are cases that are a lot worse than the other. Alzheimer's disease, I think, is one of the most cruel diseases that there is. To not be able to recognize a family member or have them not be able to recognize you, to me, is one of the worst things that can happen to somebody. And some psychiatric disorders that seem to be hereditary: schizophrenia, unorganized or delusional thoughts, and bipolar disorder, which they've got now to where they may call that. There's another couple new terms out now, but as far as this material, it goes to bipolar, which you'll have very, very bad lows followed by very long periods of time of manic behavior. They'll just go back and forth, real high 1 minute, next minute very bad mood, and sometimes even suicidal. Now, stress can cause problems with the way your body reacts. When you're under stress or sudden stress, your body starts to release catecholamines, epinephrine and norepinephrine. Now, if you're doing that, when you're in the middle of a road and you got a car coming, you're under some stress to get out of the road. Now, that at that point, that's good. Or to run away from some type of a wild animal or something like that. That type of stress is good. The epinephrine or the norepinephrine at that point, that's what it's there for. However, continued stress, those things keep being released, and it can cause problems. If your blood pressure, if your heart has to normally stay at an elevated rate, or your vessels are constricted after a period of time, that's going to cause you to have some high blood pressure issues or some cardiac issues. But what happens after a while is you kind of get used to that. It's called adaptation. The body adapts to stressors, and what they start doing is, you have a short period of epinephrine available, then it starts turning to stuff like on your adrenal glands to start releasing stuff like your natural glucocorticosteroids or your mineral corticosteroids. It starts releasing them, and then it starts releasing what they call adrenocorticotropic hormone, and that starts to release stuff. What that does a lot of times is it causes you to be overweight, because it starts to store fat when you especially got those, causes your sugar to go up naturally. Because those steroids cause your body to stay in that state for a while. And then your body gets to where it finally gets depleted from this. You get exhausted from it, and that's when people start turning to other type of coping mechanisms. They you start seeing progressive mental and physical exhaustion, illness. Finally, you talk about collapse. People turning to chemical substances and things of that matter. But stress can, in fact, kill you. Staying up for these extended shifts and things like that without rest, and what you feel, you might say, man, you feel like your mind might be wide awake, but your body can't hang, or vice versa, and that's what's going on with it. This is simply just kind of shows you what I just explained to you, but your adrenal glands sit on top of your kidneys, and someone that has a continued release of these like glucose steroids that are constantly released, that'll cause fat and stuff to be stored after a period of time. And I think I brought up the other day, if you look at John F. Kennedy in his later years, how he's had this big round moon type face. It's because he had Addison's disease, which was adrenal insufficiency. So, but what happens immediately is this increases, it causes your body to access the energy storage, metabolism speeds up, increased heart rate, blood sugar. But this is temporary. This is supposed to be temporary, not all the time. And most of us live on the edge. We stay in this very stressed environment. And what I see a lot of time is people that's been doing this. A lot of times it's people that work a lot of hours. They'll go from one EMS job to the next, and it seems like that their natural stress accommodation has been depleted, and they always have these energy drinks and stuff that they're in a lot of them smoke and stuff because they're trying to make up for the body that's releasing these stimulants. So cortisol is a hormone. It's a steroid type. That's what causes your body to get run down, and where the obesity and stuff and the poor health starts to creep in, because that starts taking a toll on your body, causing your body to get the heart disease. It causes the blood vessels to get to where they don't deal with stress, to where they'll start absorbing and holding on to the fat and stuff in your body. And what does this do with you after a while? It causes you to have a loss of normal control on your mechanism. It leads to the adrenals will continue to produce cortisol. It exhausts your stress mechanism, leads to fatigue and depression, interferes with serotonin activity, loss of sleep, and this consistently high cortisol level will suppress your immune system, be more apt to injury or disease, things of that nature. But coping mechanisms play a role in your physiological response to stress, and there's don't ever be scared to reach out if you have an EAP or something like that. But this job can it can destroy, it can kill you. Now, in order to keep up, I'm going to hit on for the sake of keeping up, I'm going to jump over to the class and of lifestyle stages developer right quick, and be kind of quick about this so we can get caught up to next week. Even if we don't hit it all, this material is not one that is real tough or anything. So I'm going to be pretty quick in it so we can just keep up with it. And there again, use your reading, your textbook, and things of that matter to be able to fill in any gaps that I might miss. So, give me just a minute here. I've got the things pulled up. Our lifespan development, we all participate in this if you live long enough, whether you know it or not. So this is mainly going to say how, hey, and people in different stages of life are going to respond to things differently. Your thing is to be aware of that. You know, a 6-year-old kid is going to act different than a 14-year-old kid. So some changes you need to look at is infant is considered age 1 month to 1 year. Anything before from birth to 1 month is considered a neonate. But infants, you know, there's neonate classes that get into a lot deeper stuff than this. However, so you may be cross with them. So one thing I'd recommend to have in your, if you don't have them on your trucks or whatever, it's worth the investment. It doesn't cover, I mean, we'll get into some fluids and stuff like that later on, but is a what they call a Broslow tape. If you're familiar with those, you know, you just measure the baby with it, and out to the side, it tells you everything like what the fluid bolus should be. It tells you like what ET tube, things like that to use. So that's a good thing. It's called the Broslow tape. You get them on Amazon, about $30. There's apps also that you can use on your phone. However, I carry one in my left pocket, and I can pull it out and look at it like that. And there's no guessing, well, where does this child lay at, or where's exactly how long this one is. This is what it should be getting at that point. And when I relay my report, like I had one here a while back, bad trauma patient, and I said, hey, this patient is green on the Broslow. So when I got there, they had the Broslow tape spread out, ready to go for it. So that's a good tool to get, you know, that's a tool of the trade. Now, I'm not going to expect you to memorize all these vital signs, but however, it is somewhat natural range. It's on the Broslow tape. But vital signs for kids, when it starts out, it's going to be very, very fast when they're born. Then it kind of drops down a little bit because your body starts to maintain. Blood pressure should be measurably to weight. And when a baby's born, they're going to be have a slight temperature. So don't be alarmed with that. Like I said, I'm going to cover this real fast just to keep up for it. So I just follow up in your book and stuff as well. But neonates, here's this type of average weight for that. Like it's on the Broslow tape that you can see. When a baby is first born, the vascular system is still doing some turns. They're going to have that, the hole in their heart's going to start to close up. And sometimes it may take longer than the other. But when we get into treating infants and stuff later, we'll talk a little bit more about that. But by week 2, neonates, well, let's see. First off, in the first week of birth, a neonate can lose some weight because it's mainly due to fluid loss, because they were used to getting nourished by their mom inside the uterus, and now that they're out, it's up to them. It's kind of like they may not cooperate right away. But after that, after about 2 weeks, you know, maybe an ounce per day, they go up, and a lot of time before 6 months, they double their weight, triple it by the end of their first year. So, but like I said, when they're first born, a neonate, it's going to make a transition from fetal circulation to independent circulation. Sometimes they need help during that part. But for the most part, neonates are primarily nose breathers. That's why they're prone to nasal congestion. That congestion they can start getting infections from that easily, and that's why we need to make sure that their nasal congestions are clear. You clear them as soon as you can. So the infant's rib cage is very, very flaccid. I mean, the muscles haven't developed yet. That's why a lot of them are belly breathers, because their muscles, the chest walls, are not really formed enough yet to help them take in and out those breaths. So infants, they have a large tongue. It's short air in the airway. The tongue is easily, as far as proportions to their mouth, it's very easily to block it. That's why sometimes they may need help at first, like putting their head in a sniffing position and make sure the air goes in. How much air do you push into a baby? You just barely squeeze that bag, because their lungs are fragile, and it doesn't take much to give them a pneumothorax. So it's just pinching 2 fingers on that bag to get the air enough air to go in. The nervous system is, babies are born with some innate features right away. Like, for example, the Morrow reflex, that's like of course, you don't want to go up to somebody's baby and see if it works, but you can clap your hand or something and see if they jump. It's called like a startling reflex. They may open their arms wide, spread their fingers, and try to grab at things. The palmar reflex, that's when, like, let's see, you can put something in its palm and it grabs your finger right away. Some people, like, I got a brand new grandbaby, went seeing her yesterday, and I gave her my finger, and she held on to it, and everybody's like, "Oh, that's so sweet. She's holding your hand." I'm like, "Yeah, it is," but I'm really thinking that's really a reflex. But anyway, let them think that. But the rooting reflex is like, and I tried this yesterday. I can touch the side of her cheek, and she's going to roll over like she's going to suck on my finger. It's called a rooting reflex, and they're constantly looking, toward the touch. They go toward the touch, or even it's mainly goes along with the sucking reflex to, like, if you stroke their mouth or their lips, they'll start like licking their tongue or like that, to where they can toward maybe the mama's nipple and stuff like that, because they're always ready to eat. The fontanelles, or the divisions, or the separated parts on top of the skull that is not fused together. They've got and they close at different age rates. Like the posterior fontanelles, the ones in the back, are usually closed by 3 months. The anterior about 9 to 18 months, and those are good indications that if they seem depressed or sunk in, that's a very good indication that this baby is dehydrated. And if the fontanelles seem to be bulging, now if they cough or something like that, you may see a little bulge in it. But if the fontanelles look like they're bulged and the baby's acting funny, or altered LC or something like that, that could be a sign of infection or some type of intracranial pressure. Now, growth plates are still in the kids' bones, and that's the bones grow from the ends. So that's why we have to be alert for, like, if they have a fracture along a growth plate or something like that. But bones grow in thickness by building on themselves, and the growth plates are at the end of the bones, or the diaphysis, and that's what, when they grow to make the bones longer and wider. Now, infants, it doesn't take much for an infant to become dehydrated. They don't have a lot of fluid in the first place, but since their bodies, they really cannot produce concentrated urine. And what does that mean is their bodies hasn't learned yet to, like, well, we need to hold on to some salt and release more water, or vice versa. So they just, what they drink in, what they can put out. So it's very easily for them to be dehydrated. In the immune system, for the first 6 months of life, for the most part, the mother's immunity does spill over into the infant to help them take care of themselves. Now, that there are times when the infant, like if the mother's in poor health, drug abuse, or something of that nature, that the infant may not get what it needs for. So they do have some passive immunities passed on to them. Breastfeeding or breast milk does bolster a lot of immunity from the mother. A lot of antibodies are passed over that the baby needs. So they say, hey, breast milk is best. Now, psychological changes, the baby's going to act different to different situations. For example, you're going to know how your kid acts. You're going to know, hey, this is the way they act when this happens or when this happens. But crying is the main way that they communicate. A lot of times parents can tell what's wrong with them just by the way that they cry. Oh, she's just putting on. So, but babies, they start forming bonds early. That's why it's very important at the beginning that the parents really bond with his kids. And they're going to start having, for example, attachments to other people, like caregivers or grandparents. I'm trying to form an attachment with mine, so she'll want to come over more. But sometimes they might get like a stuffed animal or something like that. Now, when they get older, you're going to see where they start having some separation anxiety when they get older. Separation anxiety for, like, a kid that may be in a wreck or sick or something like that, that's a good sign, actually. It's an older kid that is normally scared to get away from mama. When they start having issues like, they don't care, they may be really sick. Sometimes, a predictable environment is good for a kid. They don't need to be moved around a whole lot. That helps them form some stability, and that's where you see the separation anxiety comes in a lot. So most infants prefer that. Now, toddlers, 1 to 3 years old, like I said, I'm not real concentrating on the vital signs here, the blood pressure or anything like that. There is a formula that you can use. It's like 70 times twice the age in years, and we'll give you that. I'll have that right in front of me. I'll try to get it for you before we get into patient assessment. And of course, their temperature can range a little bit more. That's for the toddlers. Now, toddlers and preschoolers, they're at that funny age where they live in a magical world. They live in like a concrete world. In other words, if they don't see it, they can't really relate to it. When I was taking developmental psychology in college a long time ago. My son, he's 30 years old now, but when he was like 2 or 3 years old, for every stage of development that we had, if we brought someone that was in that age group, we got extra points. So I brought my child to school, and they said at this point he's supposed to be able to do these exercises. So they had all those exercises out there for him to do. So when I let him down, he ran out the door and ran off. And the professor just looked at me and I said, well, dude, he's not read any of those books. He don't know what he's supposed to do. So, it can vary. They got certain things that they're supposed to be doing. And it's a good idea to have a base knowledge of, at this point that this child should be, if they're 8 years old and they still can't use the toilet, you might need to think, okay, something's not right here. So learning psychological changes, they start speaking, which is funny, the way they understand things, the way they interact and things with other children. This is a point to where, some of this stuff is kind of important to where it's like, well, at this point, this child is, he starts to hurt other kids, or he's hurting little animals or things like that. Or if something just doesn't seem right, there might be a reason that child is not to where they're supposed to be at. I've had kids that were 6 years old before tell me, hey, my mom hocked my television last week, so I can't watch whatever they was watching at that time. And they can tell you all the different kinds of alcohol and stuff like that. I mean, to me, I'm thinking, dang, 6 years old makes you wonder what kind of environments are really in for that. School-age children, when it talks about pre-conventional reasoning, that is pretty much, they know how to avoid punishment, kind of get what they want. A lot of them look more for approval more from their peers and friends, maybe so, than what their parents are. And they even may start to even develop a conscious and stuff at this time. Now, 12 to 18 years of age, that's starting when they get into physically, maybe you get into adult content. However, psychologically, they may not be there yet. Usually a real fast growth spurt at this time where, girls are usually going to outgrow the boys at this point. It's an awkward time during life. These children, I say children, teenagers, they are able to reproduce at this point. And a lot of people don't, they may not recognize that their activity can actually have big consequences like that. So one thing about the adolescents at this age is they pretty much have they respect more so the acceptance of their friends and their peers than they do their parents. They become rebellious at a point like this. So this is a real delicate age, and we may have come across kids or teenagers that are in bad situations and may not can talk about it. I had one just the other night. I had the question away from their parents. It turned out it did start an investigation, and I went to another time is when children aren't acting inappropriate to their age groups. Now, the last thing in the world, I went to a game room one time where a 16-year-old girl was having a seizure, and she had urinated on herself. And I'm thinking, this has got to be real, because why would a 16-year-old girl do that in front of her friends? Well, her mama shows up and says, no, she's just doing it for attention. This is all for attention. And I'm like, ma'am, she just urinated on herself in front of her friends. 16-year-old girls don't do that. I think this is legit. She's like, nope, you don't know her like I do, and refused treatment. And lo and behold, this very next week, another crew went out there, same exact scenario. It was like Groundhog Day. Well, one day I went to a high school and I recognized the girl. It was that girl. She was having a seizure. No mom was there to refuse. And we took her to the hospital, and she ended up having brain cancer. So, and she died a few months later. But, that girl was not acting appropriate. A 16-year-old girl, they're so self-conscious, and they are not going to, they might do some things for attention, but I promise you, I'd be willing to bet you next house note, they're not going to urinate on themselves for attention in front of their friends inside of a teen hub game room. That's just not going to work. This is like I said, peer pressure, antisocial behavior sometimes gets in 8th and 9th grade. They may have things going on they can't talk about. They start having some identity issues that are just doesn't go along with what their what their peers, other people are doing. So I'd be pressed to say sometimes I don't relate to teenagers and stuff now. It's probably as good as I used to because I'm a lot older now. But that says something for a lot of the younger generation that's coming up that isn't too far out of this age group. Maybe they can still have a lot of valuable insight to it because I've and this goes back. I don't know if any of you watch Andy Griffin or not, but this does have a relationship we're talking about. But I was watching an interview and the Ron Howard, the guy that played Opie in that movie, come out. They said they would try to make him do certain things in the script, and he'd say, "Look, nobody at my age does that. That's crazy." So that that input really helped him because, and that's what I rely on now. I've got a partner that's she's younger than my kids, so and I know I can learn from her. I can learn from her as far as the way culture and things are now because things I may not agree with or don't know about, hey, that's the way it is, and I've got to try to be able to understand it because that's just part of this job that we're in. So early adults, 19 to 25, sometimes they can be harder than the teenagers, but honestly, I love to see that type age group coming into this field. It does give me encouragement. Thanks for later on. So a lot of things, work on work, family, stressors. A lot of them in this group are now starting to have children of their own, and they're like, wow, my mom and dad weren't so dumb, maybe. Childbirth is common in this group. They start seeing some of them may start to have issues with elderly parents starting to become a factor in them. Now, the 41 to 60 years old, I ain't gonna say that, but I'm in this group. I don't know how many of y'all are. It'd be nice to know there's somebody out there close to my age. But body is still functioning at a high level. This is a lot of time. This is the big money making years. Setting time for you're a lot of time you're still active in a big career, and you're hopefully getting things set up to where you won't have to work so hard here in a few more years. But you start to me and my wife, we both wear glasses now. I had to go upgrade to another pair the other day. That's because your eyes will not work as good when you get this age. And some people try to fight it off as long as possible. Cardiovascular health. When your heart gets older, it don't work as good. Things are starting to change. So I'm a big Red Hot Chili Pepper fan, and that one there's the chorus in one of their songs, Californication, talks about pay your surgeon very well to escape the curse of aging or something like that. Cancer incident increases in this group. Start showing signs of adult onset diabetes, which is type 2. Then look at menopause starting in the late 40s and 50s. This happens whether you want it to or not. And it takes a toll, especially on women, because they feel that maybe they're not as attractive or a whole woman anymore. And you've heard of menopause or andropause, where testosterone stops as well. And you see all these low T commercials that are on now, these testosterone commercials. The body's naturally supposed to stop making so much testosterone, but people still will try to get it and take it, because one thing is, when you're younger, you're better off at holding off cancer. Testosterone is a big promoter of prostate cancer. So, it's kind of natural. I think nature itself tells the man, okay, now that you're getting older, I'm going to stop making so much testosterone. But when men get these testosterone injections or stuff like that for long periods of time, they do increase their chances of getting prostate cancer. They also may start having problems with a swelling prostate, causing, I've seen people take testosterone injections while taking Flomax. I mean, it's kind of like the body's like, what in the heck do you want me to do at this point? So it's kind of the way maybe nature works that out for you. Exercise, diet, it's really time to start working on that. You can't do a lot about the hereditary or the aging factors. However, maybe you can try to make your body a little bit more apt to deal with it. You get to a point, sometimes you might say, man, is this, okay, dang, is this all that I've all accomplished? Or what is, my children have left the home now. That's been a big adjustment for my wife and I. We've got a small farm now. We do different things. It's kind of like we started dating again, but it's I think back when they were little, I'm thinking, my gosh, man, I didn't realize that would go away so fast. But you start having you do get a different perspective. I'm not going to try to give a big lecture here about that part, but now, whatever age you are, you look back at yourself 10 years ago, 5, 10 years ago, and you see how you have a different perspective. So the age thing with aging parents come in. We're starting to have to care for aging parents now. It's kind of like when you get the kids out of the house, you're like, all right, now, man, it's our turn, and now I've got some 90-year-old kids that I got to help with now. But I just hope to God that there's somebody there for us one day. So leading causes of death for these kids, unintentional, are one of the biggest killers in people under 44 years of age. A lot of time, unexpected, unintentional injuries. Then you start getting diseases and stuff that come along later on that may take effect. Heart disease, cancers, things like that. I've seen, cancer and heart disease is supposed to be an older person thing. However, it does happen in all age groups. Some types more prevalent than others. Older adults, they know, hey, my life is getting shorter. Every day that I live, it's one less day that I got to be on this earth. However, a lot of them have a great outlook on life. At this age of life, you usually see integrity or you see despair. Some of them, it's like I've got people in my family, some that curse everything about the way their life's turned out. And then I've got others that were born naked just like the others were, with nothing. And now that they're on law firms and they look back, man, I've had a good life. I've had a good life. So there's two ways that they look at life at this point. It's usually integrity or despair. And once they're at that point, you can't really change a lot of mental attitudes, but you do see that perspective in a lot of people sometimes. Now, the vital signs are going to be dependent. A lot of times they have medications or medical issues that takes care of that. Polypharmacy is something you're going to see a lot. Man, the medication sheets that some of these patients have when you're transported, it's hard to believe what's working and what's not. The cardiovascular system, it starts to decline because simply atherosclerosis is where those arteries and heart walls start to get hardened, and it just simply does not work anymore. The cardiac system gets stiff. You lose a lot of the vascular compliance, constriction and dilation. The cholesterol starts to build up in the arteries, forming plaques. You start getting heart rate issues, contractility issues, probably getting pacemakers and things of that nature. The diastolic pressure will a lot of time increase with age, as long with the systolic pressure. The respiratory system, the lungs also are not as compliant as they used to be. A lot of time these alveolar walls will break down and you lose surface area like COPD or things like that. These changes are, fortunately, are usually gradual, but they will start to period over a time. There's a lot of like the upper airway. Some people get dentures; they lose the support. The jawbones relax so much at night it does cause some issues with breathing. The muscles of the airway, the vital capacity decreases, which the lung volume actually decreases. The residual volume, there's just simply not enough air that they can, that they would have any reserve left over. The endocrine system, people slow down in activity, and the insulin production, it is not near as much as it used to be. That's why people a lot of time have to have insulin glucophage later on. This type 2, even the type 2, changes in mental ability will become effective as well. Sometimes get demented, Alzheimer's disease. Kidneys quit working as good. They just simply start to wear out. Things just simply doesn't work as good. They can't clear waste as good. They're more prone to sepsis and gastric issues. The hypertension can also be a kidney issue. Is simply those renal system does not filter out what it should be, and it allows for this to accumulate fluid in the lungs. Also with the electrolyte resolutions, they get dehydrated very quick. It's like, these elder people, they hadn't been doing anything well if they're dehydrated. So they start having digestion problems. They start getting incontinent because of the sphincters that start to reduce activity, and this simply doesn't work as good. The brain actually gets smaller. these people are more prone to intracerebral bleeds because the brain gets smaller. However, those blood vessels that are attaching to the skull and to the brain uh, are more easily torn. Instead of being right up next to the vessel, it's hanging down. If you stop and think, a shift in that brain mass can start to pull those vessels and stuff loose. They get a diminished number of brain cells because they simply just do not form and heal or find alternative pathways. Sometimes if one area of the brain stops working, it'll find an alternative pathway. And however, as the older they get, this system seems to drop off as well. So this is kind of like age-related shrinkage. As you see the top as a young adult, how the brain is right up next to the skull. Down below it, you see if they were to tear those vessels in a pendulum type motion, then they can develop these slow bleeds, subdural hematomas or something like that. Peripheral nerve sensation is diminished or misinterpreted. It's simply either not recognized as a sensation or something that you know before, or usually too cold or too hot. I can't visit my great grandmother unless I had to meet her on a porch because she keeps her house so hot it's unreal. Seeing and hearing goes away. Sometimes it's not so much as a hearing loss or actually not able to hear it, is that sometimes they can't even interpret. They can't interpret the sounds. Is that part? Some psychosocial changes. A lot more people are living longer, have to go. They can't live on their own, but they don't want to be in nursing homes or anything of that matter. So they have a lot of. I'm seeing a more bigger increase in assisted living situations, and of course, a lot of times at this point in life, a lot of their finances. One big major health incident can ruin somebody these days with their healthcare costs, and one of the biggest killers of older adults now is suicide. You do see a lot of older people that commit suicide. Maybe it's just because of despair. They've lost their family and friends. They've lost spouses, and it just gets overbearing for them. But I have been on several elderly suicides. So that was that quick tonight. I know it was kind of quick, and but I wanted to at least get through that part to where when we meet back at 6 o'clock on the 28th, chapter 10 is where we'll start at, and we'll be back on course then. Now, you got the modular test that said it was due tonight. That's okay. Just have it done before we meet again on the 28th. And y'all please go to resort to your text or other issues or other resources you might have on some of this information that we went over pretty fast tonight, because that is a lot. It's hard to pick up in a lecture. That really needs to be just opened up and looked at in a text or some resources to kind of sit there and go over with your head and meditate on it. All right, does anybody have any comments, questions, or concerns tonight? All right, well, the pin number for tonight is going to be, what is it? Is 120833. 120833. Well, if that's all, I'm going to shut it down for tonight, and y'all have a good time off. I start my hitch tomorrow for 7 days, and I'll see you back then. Everybody have a good one.